Our next session is going to be talking about how interoperability may help solve health equity disparities. And with us is Matt Fisher, who is host of Healthcare du Jour on our own Healthcare Now radio station, and Dan Chavez of CSHIO, that's the Santa Cruz HIO.
Thank you, and thank you to everyone listening and tuning in. So, Dan, it's great to see you. So, I know Carol just kind of gave a mouthful of the organization that you're at. So, to kick things off, why don't you give us a little bit more background about what you do on a daily basis?
You bet. Thanks, Matt. Good to see you again. So Dan Chavez, Executive Director of SCIO. It's actually now the Serving Communities Health Information Organization. It was the Santa Cruz Health Information Organization, but with the data exchange framework, as well as our 1115 waiver in California, we changed our name to expand. And as such, I'm in a very dynamic environment, really growing interoperability and health information exchange in the San Francisco and Monterey Bays area, as well as the Central California region. So it's a fun time. I started the HIE in San Diego, and this is SCIO is one of the oldest HIEs in the United States, founded in 1996. We're the oldest HIE in California. So we're having a great time. We're busy as can be, juggling lots of balls, introducing health information exchange and interoperability to the Bay Area.
So, Dan, it sounds like you, as you just said, have a very long history in the HIE world. And given that we're going to be focusing on health equity and how HIEs can help with health equity, it seems the best place to start is how do you even define health equity?
Well, it's such a great question, and it's not for me to decide. It's right, it's for the industry to decide, and it's a gray. It's an absolute, right? I mean, health equity, as a definition, is when all members of a community enjoy a fair and just opportunity to be as healthy and well as possible. So that's a tough one. It's an absolute. When we say all members of a community, right? All, and then how do you define the community? Is it a county? Is it a region? Is it a state? Is it a nation? And the answer is yes. It just depends on how we define it.
Yeah, and kind of to that point, it's, as you said, no matter what size you pick, it is probably the right way to define community. But then it seems like to actually hone it down, it's going to be driven by, who are you working for, who are you working with, and where is your focus at that particular time.
It's such, again, a great point. We so often think about this as equity as it relates to treatment, but that's just one aspect, one component of it. There's equity as it relates to wellness. There's equity as it relates to healing after treatment. So all three, wellness, treatment, healing, are all components of equity.
So kind of thinking about that, that really sounds like you're looking, very holistically, which arguably is kind of where healthcare is being pushed, dragged, or encouraged to go, depending on your particular viewpoint on it. So, but if you're taking that very holistic view, like what are some of the additional factors that you're looking at when you're trying to determine is equity present, or, conversely, what efforts are needed to help promote equity?
Another really meaty question because it depends. We're going through a national survey of HIEs right now by our National Association and conducted by UCSF. And if you look at that survey, they're asking, what do you collect as an HIE to determine equity? And it's home address, race, ethnicity, preferred languages, health-related social needs such as housing, food insecurity, transportation, substance use disorder, gender identity, sexual orientation, and then other. So these are components and data points that we can aggregate and present to try to determine some depiction, some view of equity. And to a certain degree, it goes back to it's an adage and a cliche now that your health may be determined more than anything than by the zip code where you live, right? So it's a lot more than that, obviously, but we're trying to hone in on it as to figure out how we, as an industry, depict equity or versions of equity.
So that raises the question, are those the right data elements? And from that perspective, obviously knowing, you can't speak for the entire industry, would just be very curious to know what your personal perspective is on it, of whether you think those are the right elements. Are they including things that shouldn't be there, or probably more likely, what's missing?
So it's foundational and it's a great start. But to the maybe the second question, it's really up to the community to decide. And every community is going to be different. Healthcare is fairly parochial. And as such, each part of the ecosystem, each segment of the ecosystem has their views of equity. Primary care versus hospitals versus health plans versus public health. So it's really up to the community to try to align, to really move to align that view of equity for that community. And so this really is a community initiative, right? As to how to best make this happen in a given community. And they're all very different. Skyo does business in 6 counties in Central California. One of our counties is 60% Latino. Another one of our counties is 29% Asian. So just that variable alone, I think, helps determine how those counties might define and implement equity.
So kind of given that variability, and I think as you're saying, the need to have the variability because you have to be flexible in terms of defining equity based off of the locale that you're serving or that you're working with. Does that also present a challenge, because then the concept feels so amorphous and shifting that it makes it, does that make it hard to apply kind of generalized lessons or principles that you can use across communities?
Well, yes, but we want to serve up the tools. So what we want is a common tool set and a common data set such that you can develop your own equity model. Something Mickey Tripathi said in one of the earlier presentations is sort of different versions of US CDI, right? Which is a data governance data model. And what if we had a US CDI plus for equity? What does that look like? And that may be the basis for making this happen in a little more uniform manner nationally. So absolutely. And we naturally, for a whole variety of reasons, I think some of our thinking on equity came from Medicaid, right? Our underserved population. And to your point, this is very dynamic and it's evolving, it's morphing, right? But now with new legislation as it relates to female reproductive health and gender affirming care and our aging population, right? Those are variables that also really impact how we depict and present equity.
So kind of given those variabilities of, as you said, depicting equity, what then is that next step of how do you measure it? Because I think we're kind of talking about that, defining it is very much driven by each particular location you're in. But then, it feels like the next phase, as I said, is how do you then go about measuring it to determine if you're backsliding, treading water, or making progress?
Uh, Again, another question that's just tough. And I hate to keep answering with it depends. Because are we trying to do this at the population health level? Or are we trying to do this at the individual level, at the neighborhood level, right? At some aspect of our community's level with aging or one ethnic community or one religious community. So to a certain degree, it depends at what level, macro, micro, right? Individual, are we trying to impact equity? Are we trying to impact policy in a county? Are we trying to impact budgets in a county? Are we trying to impact public health programs? So everything should have an equity lens, whether it be at the individual level or the family level, the neighborhood level, everything needs to have an equity lens. And therein lies the challenge is that every piece of analysis as it relates to health and wellness in a community needs that equity lens. And so we're defining a lens based on what we're trying to do, transactional, community, jurisdictional, policy, right? Everything needs that equity lens measure, and we've got to be very descriptive and transparent on how we're determining that lens and how we're applying that lens given the subject or the change that we're trying to enact.
No, and I think that definitely makes sense. And I probably should have chimed in on this one when the first time you gave the it depends answer, but that, warms my heart because as a lawyer, that was the first thing I learned in law school is that is the answer to pretty much every question you could ever be presented with. Uh, but, kind of more seriously, it's, maybe trying to pick off one of those areas where, you're describing that you're measuring it, is it transactional, community, any one of those. Do you have any examples of what an effective measurement might be if you're looking just at one aspect of it? And again, understanding, as you said, it is really going to be influenced, kind of the final determination will be influenced by so many other surrounding factors.
Yeah, it's fair. The pandemic taught us a lot and really brought equity to the forefront of everyone's visibility. What parts of the community were getting their tests? Where were they getting their vaccinations? Now, we did a little focus, some of this, basically on demographics, age groups, and ethnic groups as to who was getting tested and vaccinated as it related to the pandemic. But those provided some really solid examples. And even though we did our very best job to make COVID lab tests and COVID vaccinations available and accessible, those efforts didn't always take. And yet part of the challenge was collecting the information properly, right? We had to do this in mass quantities in schools, in parking lots, churches, and the like. So we probably, because we were rushing so fast to manage a pandemic, we could have done a better job, right? But I think we're getting better at this in uniformly assessing where areas or demographics or patient cohorts are being treated fairly, equitably, the same as everybody else in our communities.
Yeah, and actually that goes back to maybe another kind of fundamental question, but how is the information actually being collected? I think we might have kind of skipped over that block of the house. It's, is it in person? Is it through phone calls, mailers, or any combination of that plus others?
So it's done in a variety of mechanisms. Now, the real question is, do those mechanisms get input or are inputted, shared with the health information exchange? So therein lies our challenge, right? But most times it's with your hospital or your primary care visit. It's also collected by other mechanisms, schools, senior centers, if you're part of a social service program, right? We do a pretty good job of screens and assessments for those with food insecurities or transportation needs. So every one of those mechanisms gives an individual the opportunity, for the most part, not 100%, there are no absolutes here, to input as to some of those equity variables.
So now I'm going to pick up on the question that you said I probably should have asked, and I think which is the natural outgrowth which is assuming that information is actually collected, is it being shared with the HIE?
HIEs are working very hard to make that happen. HIEs are working very hard to get all aspect of health and wellness, medicine, community-based organizations, social services agencies being part of health information exchange. In California, it's law. The law is AB 133, called our Data Exchange Framework. I think California was one of the first states to do this, is to actually make it part of law that these things need to be shared, not only with HIEs, but between care providers, not just clinical providers, but social service agencies and community-based organizations. So in California, we have 9 qualified health information organizations. We don't call them HIEs anymore because now it's that superset of information, right? And so by law, this information is to be shared.
So even though the law is there saying it has to be shared or should be shared, is that occurring? Because as we all know, just because the law is there doesn't mean compliance happens overnight.
It does not happen overnight. Nothing in interoperability happens overnight. I mean, we've been trying to do FHIR for 10 years. So it is happening slowly but surely. We're about halfway through in our implementation. And what I mean by that is adoption of the data exchange framework. So it's happening. We're 2.5 years into it. We have a long way to go. We'll get there, but it's going to take a while.
So if you said you're roughly halfway done, I think you said with the infrastructure at this point, what areas have been surprising that have actually worked better and gone more quickly than you anticipated?
Well, it's a close race. Uh, we're seeing some great movement on post-acute care, believe it or not. Our skilled nursing facilities may be leading the pack. And our skilled nursing facilities have traditionally not shared with HIEs in the state of California. Again, I can only speak for the state of California, but as a rule, they're coming on board pretty well.
Yeah, so that's good to hear because it feels like, if you're talking about adoption of electronic records, post-acute was kind of left out of the picture.
Correct.
And, to see that, as you said, that the strides are being made, that supports what you've been talking about, which is the recognition that connectivity is required as well as that broad picture of what is happening with individuals.
Wonderful point, a really important point because they were ignored. And wherever you have transitions of care that are routine, drives demand for what we're talking about, Matt, right? The more times that a person or a patient has to be handed off from one institution to the other is where you see the greatest requirements for health-related social needs or the social drivers of health. Because those other considerations that make the difference in outcomes, care, person satisfaction, etc.
Yeah, so if we're talking about, where areas of transition or, the need to have information available and flowing back and forth and around where, patients are experiencing different, care interactions, and then going beyond kind of that post-acute, what other kind of community-based organizations or, maybe just call it non-traditional healthcare organizations are being brought into this picture using California as the example, since, as you said, that's where you're most familiar and also where, as you're describing, the law is mandating it. So who's being brought, kind of pulled into it that may not have expected the need to have to build this kind of technology infrastructure?
Well, as many as possible. We talked about some 3 highlights, right? Housing, food insecurity, transportation, but that expands to others immediately, like aging services, as an example. More having to do with education and keeping our children in school. So there, anywhere there's a barrier to health, wellness, education, family dynamics, those social services agencies, those community-based organizations have to be brought into the fold. And we're
So
actively soliciting and trying to make that happen.
And as you're going through that solicitation and engagement process, what type of education are you having to provide to those organizations about how they need to go about collecting and then sharing their data? Because we can get into, data standardization in common formats separately, but, at least you have, if you have like a hospital or a physician group, they've been theoretically hearing about standards. Maybe these community organizations have been completely ignoring it because they haven't had to even think about it.
Well, let's put the standards aside for a second, right? But why is this a good thing? Why should you do this? Why should you trust the system to share more? It's not a question of vulnerability. It, we talk about the value of whole person care. The better that we as a health and wellness ecosystem can give that total picture of an individual, their health, their wellness, and their challenges, the better we're going to be able to provide care for them. The less they're going to have to do to get that whole person care, which is what I think we can appreciate everybody wants.
And what's the typical response as you're kind of initially talking to an organization that hasn't had to think along those lines before?
Fears of privacy, fears of stigmatization. I'm not sure I want my caregivers to view me this way. It may be accurate, it may be true, but I'm afraid of what somebody's going to think about me, right? Giving people the understanding that they have the right to protect this information should they desire. And that's a challenge. In the state of California, we have 2.7 million that don't have a great understanding of English. That's 7% of our population, right? So this has got to be understandable.
Yeah, and I think as you're saying there, you're kind of underscoring there is, there are just a lot of challenges, and that's just on the initial collection and sharing front. And I know we just said a minute ago we're going to leave standardization to the side for a second, but that now seems to feed into that discussion. I imagine you're probably gathering information from a whole host of locations that are all collecting it in different forms. So, is the HIE playing that role to help, standardize it, or, where is that process occurring?
We do our very best, right? And if it fits in a nice field with standard definitions, that works. But we're also making things available that are free text without the standards. But
So,
so it's one thing to collect, but it's also the other challenge is to present it, right? And our electronic health records, which do a great job with a lot of things, don't always do the best job of presenting some of the equity challenges of an individual. And I think that's where an HIE really excels, is that we have a little bit more flexibility in how we present data, right? EHRs are documentation systems, they're billing systems, they're even more structured in their intake and presentation of data, where an HIE or an HIO or a health data utility has got tremendous flexibility. And so we can flag some things and make it readily available to the user, to the caregiver, so such that they can take action.
and I think kind of your use of flexibility there is a nice way of saying you're kind of in that place where you're able to reflect the actual need, where as opposed to potentially, from some perspectives being stuck in a box and, having to fit parameters that aren't necessarily kind of meeting what users or the community is looking for in that operation.
Well said. Absolutely. Not necessarily a need, but a challenge or a barrier or an inhibitor such that this person can get well or get back to work or get back to being engaged in what they do.
So in light of a lot of the different things that we've been talking about, you've talked about a lot of progress, a lot of challenges still to occur. You know, what do you think, what do you kind of see the future looking like? And what kind of immediate actions do you think need to occur at the beginning of next year? And, what kind of timeline progression would you like to see, be followed. Obviously, understanding that a short-term prediction might be the only thing that you have a remote chance of accurately being able to predict.
So I think it's a very promising time, given what we have just been through with the pandemic and a variety of other challenges, that our folks are much more open and ready to share some of these things. They realize how some of these equity issues have been true barriers and challenges to making things happen. If we want outcomes, what's going to happen first? Health outcomes or health equity? Well, I think they go hand in hand. And I think just now we recognize that in order for us to have health outcomes and health quality, we need the equity piece. And that's probably a little bit more qualitative in a variety of ways. A lot of our quality measures have been reimbursement based, claims based to date. And we need some of this other information. We've seen a tremendous uptake in closed loop referrals. We've seen a tremendous uptake in coming out with a care plan when you're discharged from the ED or the acute environments. That is all recognition of dealing with some of these equity issues. So I think it's a great time, and we're going to see more of it.
And are there any particular changes, whether from a statutory or legislative, regulatory, or other kind of purview that you feel are required or would be helpful to, better drive the ability to achieve those goals?
Well, we're certainly doing it in California with our 1115 waiver called CalAIM and the AB 133 I referenced with the data exchange framework. We are legislating this. It's an adjustment. I mean, people, institutions aren't used to being told to share. It sounds a little juvenile, right? But it is now law in the state of California, and it's got to happen in a comprehensive manner, right? HIPAA still applies, minimum necessary still applies. So we're still a little bit contradictory between minimally necessary and whole person care, right? Do I just send the medication list and the allergy list, or do I send that whole person view of this individual who's got some other challenges, beyond allergies and medications?
Yeah, and that really begs, as you said, kind of the situation by situation determination of what is actually the minimum necessary, because sometimes minimum necessary is all of the information.
Correct.
But then I think that touches upon another point you'd raised, which is that fear of sharing, because there's always that concern of potential repercussions if something were to go wrong and the information leaks out where you didn't intend it to.
Correct. But by the same token, we're also driving patient engagement. And we've got to deal with the trust issues. We've got to deal with the security issues. We've got to deal with the stigma issues. And that is one of the values of health information exchange. It is a dedicated, secure, private network, only to be used for caregivers, for people's health and wellness.
And I think that's, another good framing around it, which is it's, just like all the systems, it's not, kind of free game or free reign to get
Correct.
access to the data. So it's, kind of similar in that regard to some of the other regulatory structures where it can be very permissive, but permissive within the realm of who actually needs to get at the information.
No question. And let's please not forget, this helps caregivers as well. It's not just good for the patients and the individuals. It's helpful for the system, the doctors, the nurses, the caregivers, so they can do their jobs.
Yeah, and again, another important piece to keep in mind, because as you said, it's there is that growing recognition around the full scale of who is involved and who needs to be aware of what's happening. And Dan, we're getting really close to the end of our time, so it's kind of want to give you a chance for a final parting thought about what do you think is going to have the biggest influence on this discussion in the coming year?
So I think it's a growing acceptance of health information exchange at every level, at every institutional level, at every community level, at every individual level. Health information exchange is a good thing. It's good for health and wellness. It's good for our communities. I think there's that acceptance. Now, unfortunately, I think the pandemic really helped that. And I just think we need to keep carrying that momentum, that energy, do the things that we need to continue to do with public health, with primary care, with wellness, and the like.
Yeah, well, a lot to be optimistic for. So, Dan, thank you so much for the time today, and